So welcome to another session. In this session we will be discussing about pulmonary hypertension. We will be discussing its classification, diagnosis and management strategies. So pulmonary hypertension is described and defined as pulmonary mean PA pressure more than 25 millimeters of mercury at rest on right heart catheterization. So normally pulmonary pressure in between 14 plus minus 3 millimeters of mercury with approximately upper limit as 20. So normally 20 is the cutoff. The clinical significance between 20 to 24 is unclear, but mean 25 is considered as pulmonary hypertension. So patients who present with pulmonary artery pressure in this range should be evaluated for developing a PH later on, like in connective tissue disorder or familial disorder. Now, hemodynamic definition of pulmonary hypertension includes, hence, pH is said to be present if the mean is more than 25. You call it pre-capillary or you call it post-capillary, depending on if mean is more than 25, and if the wedge is less than 15, then you call it pre-capillary. If it's post-capillary, then the wedge pressure will be more than 15. So, the causes of pre-capillary are pulmonary arterial hypertension, lung disorders, thromboembolic PAH, patients with multifactorial disorder can present with either of them. Patients with left heart disease would come with a post-capillary PH. These can be either isolated post-capillary PH or this can be combined pre and post-capillary PH. Now, these can be differentiated based on assessment of pulmonary vascular resistance and also by looking at the diastolic pressure gradient, which is diastolic PA pressure minus mean PA wedge pressure. If that gradient is less than 7, it's called as isolated post-capillary. If gradient is more than 7 and pulmonary vascular resistance and or is more than 3 Wood units, then you call it combined. So, post-capillary can be isolated post or combined, which can be defined by looking at the diastolic pressure gradient and pulmonary vascular resistance. So, this is the definition of different types, hemodynamic types of pulmonary arterial hypertension. So, pH is basically a hemodynamic pathophysiological condition which is defined by increase in the pressure assessed by the right heart cath, and pH can be found in multiple conditions. So, pH group 1 is the clinical condition which is characterized by pre-capillary pH and the pulmonary vascular resistance is more than 3 Woods in absence of other causes of pre-capillary pH like lung disorder or thromboembolic phenomena. So, pH hence include different form of clinical pictures, and there is no sufficient data for the definition of the same in the long run. So, comprehensive clinical classification of PAH hence is categorized as PAH with idiopathic is class 1. So, pulmonary arterial hypertension, idiopathic, hereditary, which is BMPR2 mutation, other mutation, drug, connective tissue, HIV, portal, congenital and schistosomiasis are categorized 1. In patients with persistent pulmonary hypertension, the newborn also falls into this category, and patients with veno-occlusive disease or capillary hemangiomatosis with EF2AK mutation or other mutation or drugs or connective tissue and HIV will fall also into this category. 2 is due to left heart disease with like LV systolic or diastolic dysfunction of alveolar heart disease. 3 is because of the lung disorder. 4 is thromboembolic phenomena like CTEP, angiosarcoma, arteritis, pulmonary vein stenosis, congenital artery stenosis, and class 5 is unclear or multifactorial like hematological disorders like chronic hemolytic anemia, myeloproliferative disorders, splenoectomy, histiocytosis, sarcoidosis, etc. Metabolic disorder like glycogen storage, Gaucher, thyroid, and pulmonary tumoral thromboembolic angiopathy, fibrosing mediastinitis, renal failure, etc. are part of this. So, the clinical classification has been updated by Simonet et al., which talks about idiopathic, hereditary, drugs and connective tissue associated as 1, 2 of course the left heart, 3 is the lung disorders, and then you have 4 which is the pulmonary arterial hypertension, and 5 is the one that we discussed as multifactorial. So, the pH associated with congenital heart disease like Eason-Manger and pH with prevalent systemic to pulmonary shunts will fall into this category. This includes all large intra and extra cardiac defects which begin as systemic to pulmonary shunt and progress with time to severe elevation of PVR and to reversal of pulmonary to systemic or bidirectional shunting. Cyanosis, secondary erythrocytosis and multi-organ involvement are usually present. So, pH associated with prevalent systemic to pulmonary shunts can be correctable non-correctable, and it includes moderate to large defects like PVR in mildly to moderately increased systemic to pulmonary shunting, whereas cyanosis at rest is not a feature. PH with small coincidental defects, that is marked elevation in PVR in presence of small cardiac defects, usually ventricular septal defects like less than 1 mm, ASD more less than 2 mm. They themselves do not account for elevated PVR in the clinical picture. They will hence should be treated like idiopathic PAH, and because disclosing the defect is contraindicated. Patients after the correction, however, with PH which is still remnant or prevalent after the correction of the defect in absence of significant would be the separate category. So, precapillary PH is associated with chronic hemolytic anemia. This is different from the other form of PH due to absence of plexiform lesion in histopathology, and also a low PVR and high cardiac output with response to PH therapies with no demonstration of efficacy being found in this subgroup of patients. So, these conditions have been moved from group 1 PH to group 5, and group pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis are being expanded and included as idiopathic, hereditary and drug and toxin related association. Now, coming to genetics, group 1, the commonest mutation is heterogeneous BMPR2 mutation, which is present in 75% of familial PH and 25% of sporadic cases. BMPR2 basically encodes type 2 receptor for bone morphogenetic proteins which are involved in vascular cell proliferation. Mutation of gene coding to activin receptor like kinase 1 and endoglin have been identified in PH patients with personal and family history of hereditary hemorrhagic telangiectasia, as well as BMPR1B and SMAD9, supporting the prominent role of TGF-beta family members in PAH. Whole exome sequencing has identified rare heterogeneous mutation encoding for CAV1 and for KCNK3. The hereditary PVOD, PCH have been recognized in consanguineous families, suggesting recessive transmission. Whole genome sequencing demonstrated the biallele mutation of eukaryocytic translation initiation factor 2 alpha kinase 4, which is present in all familial PVOD, PCH in 25% of histologically confirmed sporadic cases also. So, these encode serine threonine kinase present in all eukaryocytes. That can induce changes in gene expression to amino acid deprivation. So, the possible drugs that have been implicated include fenfluramine, dexfenfluramine, aminorex, rapeseed oil and SSRI if there is increased risk of persistent pulmonary hypertension in newborns or mother who take this. Likely is also with L-tryptophan, dasatinib, amphetamine and amphetamine, possibly cocaine, phenylpropylamine, interferon A and B, St. John's wort and alkylic agents like mitosine C and cyclophosphamide can cause veno-occlusive disease. These patients usually present with symptoms of RV dysfunction. Typically, they have shortness of breath, fatigue, weakness, angina, syncope. Less commonly, patients also describe dry cough, exercise-induced nausea and vomiting. Symptoms at rest occur only in advanced cases. Abdominal distension, ankle edema will develop with progressive RV failure. The physical signs include left parasternal heave, the accentuated P2, RS3, pansystolic murmur at tricuspid valve including diastolic PR murmur and the TR murmur. The elevated JVP, hepatomegaly, ascites, peripheral edema, cold extremities are the other features. Clinical features for the underlying cause like telangiectasia, digital ulceration and sclerodactyly would be feature of scleroderma, while Velcro-like inspiratory crackles would suggest interstitial lung disease. Spider nevi, testicular atrophy, pulmonary edema or stigmata of liver disease or cirrhosis may also suggest the etiology. Digital clubbing, PVOD would represent congenital cyanotic heart disease or liver disease or interstitial lung disease. Once a patient is encountered, you need to do ECG, chest X-ray, echo. You also do pulmonary function test, VQ scan, HRCT, sometimes with pulmonary angio, cardiac MR imaging, blood test, immunology, abdominal ultrasound, right heart cath and also vasodilatory challenge test and pulmonary angiogram. ECG would usually show pulmonary hypertension with P pulmonale, right axis, RV hypertrophy, RV strain, RBBB. RV hypertrophy has got a very insufficient sensitivity and specificity and has been used as screening tool, but RV strain is most sensitive. Prolongation of QRS and QTC may suggest severe disease. ECG differential diagnosis includes a myocardial infarction. Chest X-ray may show central arterial dilatation with contrast with loss to what is called as peripheral pruning of peripheral bloods. Right atria and right ventricle is enlarged in more advanced cases. Chest X-ray may help in distinguishing arterial venous pH by respective demonstrating increase and decrease arterial to vein ratio. Overall, the degree of pH in any given patient does not correlate with the extent of radiologic abnormalities. As for ECG, a normal chest X-ray does not exclude PAH. PFT and arterial blood gas, although diffusion capacity can be normal in PAH, most patients have decreased lung diffusion capacity for carbon monoxide. An abnormal low DClCO2 defined as 45% of predicted is associated with poor outcome. The differential diagnosis of low DLCO2 in PH includes PVOD, PH associated with scleroderma and parenchymal lung disease. Although airflow obstruction is unusual, peripheral airway obstruction can be detected. Due to alveolar hyperventilation, saturations can remain normal and slightly lower than normal with PSO2 is decreased. Prevalence of nocturnal hypoxemia and central apnea are high in pH of 70 to 80%. Overnight oximetry or polysomnography can be used to identify obstructive sleep apnea. Echo can be performed when pH is suspected, and this can not only pick up the abnormality and the extent of pulmonary right ventricular systolic pressure. When treatment of pH is considered, echo alone, however, is not sufficient to arrive at a diagnosis and should require a cath. If the echo is not sufficient, you will have to do a cath and you have to assign a level of probability for pH, and this should not be defined as a cutoff by just RVSP. So, echocardiographically, if the velocity is less than 2.8 and there are signs of pH present, then your probability is intermediate. But if the pH pressures are high and if the RV velocity is more than 3.4 meter per second and IVC is 30 millimeter with RV by LV ratio more than 1, then it's intermediate risk. But in this velocity range, the patient is high risk. Other echo criteria include assessment of ventricles, PA and IVC-RA, RV to LV ratio more than 1, RVOT, Doppler acceleration time less than 105, and IVC diameter more than 21 with decreased inspiratory collapse are features of inferior vena cava. Flattening of interventricular septum, or also called as the eccentricity index, which is the left ventricle ratio of the eccentricity in the transverse to longitudinal diameter. If it's more than 1 in systole and or diastole, it is again a feature of the pulmonary hypertension. PA diameter more than 25 is also an important criteria. RA area more than 18 and RV diastolic PR velocity more than 2.2. So, this is how it would look like. IVC diameter is more than 21 with less than 50% collapse and RA area more than 18 on echocardiography. Also, you can see RV PA coupling, which is the RV outflow Doppler acceleration time is less than 105, and there is early pulmonary diastolic PR with the velocity more than 2.2 meter per second with PA diameter more than 25. So, these can be used to assess the low, intermediate and high risk probability. In patients without risk factor of associated PH or CTEP, alternative diagnosis should be considered in low, alternate diagnosis should be ruled out, and further investigation of PH is required in high risk is class 1. So, echo follow-up, further evaluation of pH and further investigation of pH is recommended if the high risk subgroup of patients. A VQ scan should be performed to rule out CTEP. A VQ scan as a screening mode because it's of high sensitivity compared to CTPA. In the experience center, low or normal probability of VQ scan exclude CTEP with 90 to 100% sensitivity and 94 to 100% specificity. But CT pulmonary angiogram with high contrast CT thorax, the suspicion of PH is symptomatic patients with those who have PA diameter more than 29 and PA to aorta ratio of more than 1. Artery to bronchus ratio more than 1 in 3 or 4 lobes also is a diagnostic finding of PH. In pulmonary vascular obstructive disease, central ground glass opacification with thickening of interlobar septa may be also present. Traditionally, pulmonary angiogram was required for CTEP to identify those who benefit from pulmonary endarterectomy. Blood gas and immunology will help in localizing the etiology. LFT, which is liver function test, is important before you start therapies like endothelin receptor antagonist. Thyroid function, connective tissue disorder, HIV, up to 40% of idiopathic patients may have ANA, which is in low positive titer. Scleroderma also has likely limited scleroderma of anti-nuclear antibodies like anti-centromere, anti-dsDNA, anti-ROLA, U1 RNP can be positive. Positive U3 RNP is suggestive of diffuse scleroderma. Right heart cath is required as a confirmatory gold standard test for PAH and CTEP. It also will assess the severity of hemodynamic impairment, and more importantly, you can do a vasoreactive testing. So, threshold for left heart cath for the right heart should be low because you are already going invasive, especially in patients with coronary artery disease or heart failure. Measurement of LV end diastolic is also important to avoid miscalculation for elevated wedge pressure when an unexpected setting is found. So, the measurement of PA wedge is unreliable. Left heart should be considered to assess LV EDP is class 2A. It should be considered in suspected patients with left heart disease is 2B, and it's again indicated in patients with chronic thromboembolic pulmonary hypertension to confirm the diagnosis as class 1 indication. Other vasoreactive testing is usually recommended in expert center. It's recommended in all pH therapies where you want to consider calcium channel blocker, because calcium channel blockers will work only in patients who are vasodilatory sensitive, who respond to vasodilator challenge test. You cannot inject everybody and start CCBs to everyone. So, for that you need to see, because only 10% of patients are vasodilatory challenge responder, they are vasodilators, and only then the CCBs would be recommended. Otherwise, giving CCBs in these patients can actually worsen their heart failure. So, positive response is defined as reduction of PA pressure by mean of more than 10 with an absolute value less than 40 without any decrease of cardiac output. So, nitric oxide is preferred agent, but again it is not easily available, so is epoprostenol. So, in that substitute usually adenosine is used, which is a class 2A agent. For assessment, inhaled iloprostrate is 2B. Oral CCBs is not recommended, and neither vasoreactive testing can be safely treated with high doses, is not recommended for idiopathic PH hereditary or PH associated with drugs. Molecular assessment for the field of genetic counseling for pulmonary arterial hypertension is also recommended. Patients with familial or sporadic veno-occlusive or capillary hemangiomatosis should be advised to undergo the same. PMR-PR2 mutation in patients with idiopathic PH or induced by anorexiogens to patients with family history of PH is common. When no BMPR2 mutation is there, in those cases the family history identified in patients with IPH 40-year-old, or when PH occurs in patients with a personal or family history of hereditary hemorrhagic telangiectasia screening of ACVRL1 and ENG genes can also be done. If no mutation is found in these, then the mutations are rare, KCNK3 and CAV1. So, in that case you can even EIF2AK4 mutations can also be found in familial PVOD-PCH. So, once a patient is having symptoms, signs and history of PAH, echocardiographic probability of PH is high, then you do a left heart cath, lung disease, symptoms, signs, risk factor, ECG, PFT, DLCO, chest X-ray, HRCT, disease of left heart and lung is confirmed, then no signs of severe PH-RV dysfunction, you can treat the underlying cause, VQ scan if there is a mismatch, you send to the PH center, rule out CTEP, and then if required you can do a right heart cath when mean pressure is more than 25, wedge pressure is less than 15 and PVR is more than 3, the pH is likely, and then you rule out the other disorders which we have discussed above. So, echocardiography should be performed when PH is suspected, it is not sufficient to support, right heart cath is preferred. Screening in asymptomatic patients with PAH, the new diagnostic algorithm should help in more systematic approach of PAH. So, the echocardiography is class 1 first non-invasive, VQ scan is the case as well, and so is CT pulmonary angio and the other investigations. Now, let us come to specific groups. PAH group 1, in them the resting echocardiography is again class 1, and so is the mutation assessment if you find it in familial patients. Exercise echo is not recommended to PH recommendation. Again, in patients with PH, it is recommended to perform right heart cath in expert center because it is technically demanding. Assessment of PH, hence you have the categories of low, intermediate and high risk. Patients are said to be in high risk based on their 6-minute walk test if it is less than 165 meter, versus low risk if it is between 440 meters and above. The in between is the intermediate range. Patients who are class 4 are high risk, 1, 2 is low risk. No syncope. Syncope is common in high risk patients, and signs of heart failure are also present, and prognosis is also very rapid in these subgroup of patients. VQ, peak VO2 when done by cardiopulmonary exercise testing would show less than 11 versus 15, which is 35 and 65%. NT-proBNP and BNP are elevated, and you can see the RA area more than 26 compared to 8, with RA pressure more than 14, cardiac index less than 2, and SVO2 venous saturation less than 60%. So, once you have done the testing, you would repeat them every 3 months, 6 months, or according to the medical assessment ECG, 6-minute walk test, CPET, which is the cardiopulmonary exercise testing, can be deferred a bit. Basic labs are done every visit. However, extended lab can be done 6 months to annually, and blood gas also same, with right heart cath also maybe annually. Now coming to treatment of PH, the recommendation for treatment is diuretic is recommended if you have fluid overload and right heart failure, while continuous O2 therapy in PH patient with saturation less than 60% is also class 1 indication. Oral anticoagulant may be considered in patients who are due to anorexogens, correction of anemia, and use of ACE inhibitors, ARBs, beta blocker, ivabradine is not recommended with PH unless you have comorbidities like heart failure of left heart. Calcium channel blocker on high doses is recommended in only responders on vasoreactive testing. Close follow-up for every 3 to 4 months for right heart also may be done when they are being treated with CCB. Continuing the CCB is recommended in class 1, 2 with marked hemodynamic improvement, and specific PH therapy should be recommended for class 3, 4 patients even without hemodynamic on CCBs. So the various drugs that are available, functional class 1, you can choose endothelin antagonists across the class, which is ambrisentan, bosentan and mesisentan. Tadalafil, sildenafil, viredanafil are the PDE5 inhibitors which are used. Guanide cyclase stimulator, which is cyclic GMP analog, is Riocigua. Riocigua is also recommended in patients, especially is the only preferred therapy which is evaluated in CTEP, which is cardiopulmonary thromboembolic pulmonary hypertension due to chronic embolism, pulmonary embolism. You can use prostacyclin analogs, but most of them are oral. Beraprost is the IV. Beraprost is the oral one, but it's not very proven one. So ipraprostenol, iroprostenol, treprostenol are preferred in functional class 4. But now you have evidence for selexipag, which is already available in West and will now be available in India. It's a prostacyclin analog, which is a receptor antagonist, and it's recommended is class 1 in functional class 2 and 3 patients. So in patients who are functional class 2, you can choose combination also ambrisentan and tadalafil or other endothelin receptor antagonists with PDE5 inhibitors across 3 class 2 to 4. IV would be preferred only in patients who are class 3 or 4, while triple therapy would be again recommended in class 3 or 4 patients. Hospitalized in ICU in patients with heart rate more than 110 and less 90 systolic is recommended if the patient is functional class 4. Inotrope support is required for hypertension, lung transplant for class 3 and 4, and balloon atrial septostomy when refractory heart failure is present can also be offered to these patients. So once PH is confirmed and you've assessed him by vasoreactive testing, and you can put him on CCB, but if it's non-reactive, you can start with monotherapy in functional class 1, 2 or 3, but in class 3 and 4, you can choose combination therapy of double or triple in a sequence. Selexipag is oral active prostacyclin IP receptor agonist. Its metabolite has shown similar mode of action to that of pharmacologically. They are distinct from the prostacyclin, and they have shown to reduce PVR after 7 weeks in their studies. A large study called Griffon study was also very much in favor, and it's currently approved now for PH management. PVOD and PCH, the pulmonary veno-occlusive disease, there will be dyspnea on rest, basal crepitations, digital clubbing, low DLCA2, subpleural thickening, central lobar ground glass opacity with lymphadenopathy, and hemosiderin-laden macrophages with normal PA wedge pressure. In these group of patient, combination would help you identify, you would suspect E1F2 AK4 mutation, and referral for the same for transplant is preferred, and in those centers where the transplant should be managed with extensive experience only. POPH, which is pulmonary arterial hypertension with portal hypertension, echocardiography assessment of PH is recommended, and also in these patients there will be expert center where the treatment algorithm should be applied for the same, taking into account liver disease. Anticoagulation is not recommended in patients with PH with portal hypertension. Liver transplant may be considered because that may be therapeutic for it itself. So liver transplant is contraindicated in severe uncontrolled PH. In congenital heart disease, which have Eason-Mangarized, PVR, which is pulmonary vascular resistance, index, which is less than 4, it's correctable. 4 to 8 is individual patient assessment. This is class 2A indication, but in tertiary center, but more than 8 is of course not correctable. So in these patients with congenital heart disease, bosentan is the preferred agent. Other endothelin antagonists, PDE5 and prostacyclin should be considered. Also in presence or absence of hemoptysis, oral anticoagulation can be considered with suspected pulmonary thrombosis or signs of heart failure. A supplemental oxygen is given to produce O2 saturation to be maintained. A phlebotomy with replacement of the isovolumic saline should be done when hematocrit exceeds 65%. Use of supplemental iron can be given in those with low ferritin levels. Combination should be done in Eisenmenger syndrome. Calcium channel blockers are contraindicated in PAH because of Eisenmenger syndrome. In HIV patients, echocardiographic screening for PH is not recommended unless you are symptomatic. HIV patient with the treatment algorithm will remain the same, and anticoagulation is also not recommended. In left heart disease, you must optimize the left heart hemodynamics. So, treat the underlying etiology like mitral stenosis or diastolic heart failure, and then you also need to treat other causes like COPD, sleep apnea, etc. And then invasive assessment can be done in sometimes to assess the volume status, and pre-capillary component of indicated high diastolic pressure gradient or high PVR should be referred to expert center for evaluation of the same. PAH approved therapy is not indicated in these subgroup of patient, and role of vasoreactive testing is not very much established again. In patients with hypoxic lung disease, in patients with COPD without pH, which is mean PA pressure less than 25, if it's more than 25 you call it pH is present. In severe pH is defined as mean PA pressure more than 25 presence of low cardiac output. These patients, apart from echo, referral and treatment of underlying cause, you will have to do right heart cath, and not essentially in these patients. They can be done optionally only, and unless therapeutic consequences are expected or the same. Yugs drugs for VR pH are not classically indicated in these subgroup of patients. In patients with CTAP, the diagnosis is established by assessment of signs and symptoms and echocardiographic probability and VQ scan. If it's present, you can do a CTPA or do a referred center assessment by invasive angiogram. And once that is there and it's found out that the patient is confirmed, you will have to give a lifelong anticoagulation. And if the surgery is possible, the very few surgeries centers which can do pulmonary endarterectomy, because they dissect the whole of the thrombus up to the branches of the pulmonary heart and take those out. If it's not possible, then you will have to give these patients a balloon arterial plus angioplasty if possible. In persistent PH, as I said, you can also use Riosigua as the preferred line of treatment. So, Riosigua is recommended in symptomatic patient of CTAP after surgical or inoperable CTAP patients, at least with one experienced PEA surgeon. Again, PE survivors, CTAP may be considered, who have dyspnea, lifelong anticoagulation is recommended, and deep hypothermic circulatory arrest is preferred. Off-label use of PH therapies is not class 2B only. You can do balloon angioplasty of pulmonary artery with non-operable cases with unfavorable risk for surgery. Screening for CTAP in asymptomatic survivors of PH, however, is not recommended. Hematological disorders, systemic disorder, metabolic disorder, multifactor disorder, additional diagnostic criteria will include for group 2 wedge pressure more than 15, group 3 respiratory pap swings, or PVR in CML, or dasatinib PVR is elevated. So, these are some of the examples where you will have to do certain other tests to confirm and rule out the same. So, again another example, PH specific indicated therapies. When you look in class 1 patients, you must give. In class 2 patients and 3 patients, they are not recommended to be given endothelin antagonist or PD5 inhibitors. Do not give it for left heart, do not give it for lung disease unless the PH compelling indication is there. Same is the case with group 5, but in class 5 patients you can still use PH indicated therapies. So, this brings us to the end of management of pulmonary hypertension. I have covered the classification, the Venice classification, which was then later replaced with the newer WHO classification. Their functional classes are also should be known, how the importance of 6-minute walk test is there in these patients, and based on that also we need to look what therapies are available, including the newer therapies like selexipag, which is an oral prostacyclin analog or receptor agonist. Thank you very much.